Welcome to the talk on innovations in care and management through COVID. This is part of the Living with Epilepsy conference. My name is Jesse W. Mendel, and we're going to try to cover an overview of the changes that took place during COVID, both locally, regionally, nationally, and internationally, based on the COVID virus and the interaction of institutional policies, both on the inpatient and outpatient side. We're also going to talk about some of the effects that those things had on epilepsy patients and epilepsy caregivers. And then we're going to talk a little bit about going forward, what we expect to see. So the brief overview, the impact of COVID on epilepsy patient care, interaction between patients and caregivers and COVID-19 and the healthcare system, and then changes to healthcare moving forward. So there were significant changes to our practice and then worldwide with regards to epilepsy patients. We saw reduced admissions for epilepsy patients as far as diagnostic workups. We saw a reduction in inpatient procedures at times during COVID. Elective procedures, which some of ours are considered, were either reduced or stopped completely. In Ohio, there was a significant period of time in 2020 where there was a halt to all elective procedures. And this led to delays in treatment for a lot of patients. And there were different components to that delay. One component being on our side with the reduced ability to do procedures and a reduced ability to do the testing that people needed, and also on the patient side where there was in many cases a lot more hesitancy to get tested, to get evaluated, to have procedures done because of concerns about catching COVID in the hospital or catching COVID really just out in the community. As far as outpatient care, also significant changes. Early in the pandemic, we were able to transition most of our outpatient operations to telehealth. So internally, that included all of our internal meetings and conferences. That also meant, as far as clinic appointments, trying to route patients who were appropriate to telehealth visits as opposed to in-person appointments. That also meant that there might be more of a delay for people that needed to have in-person appointments to get seen, and an increase in general stress. So that stress occurred in providers, it occurred in clinic staff, it occurred in our patients and in the community at large. Overall, in Central Ohio, most of the hospital systems did relatively well during this transition. For example, in other countries like Spain and in Italy, places where there was a complete lockdown and a reduced access to internet services, or they didn't have the ability to do video appointments, there was a complete removal of clinic appointments for a significant period of times, and a complete removal of access to inpatient services except under emergency conditions. So overall in Ohio, in Central Ohio, and with us specifically, we've been able to do relatively well comparatively. And part of that is related to the fact that very early on, there was a concerted effort to ensure that even in worst case scenarios with hospital admissions and worst case scenarios with critical illness, certainly in 2020, that we had as much capacity as we thought that we needed. And as far as critical care services, we never reached a point where we were utilizing, even half necessarily of the facilities that we thought that we might need and that we had prepared for. As far as COVID on general hospital operations. It was primarily reduction in elective procedures and delays in treatments that led to major changes within the hospital system. On the outpatient side, this was mostly managed through this transition to telehealth, which we were able to accomplish in just a few weeks. If you look on the inpatient side for our epilepsy group specifically, so these were scheduled admissions for diagnostic epilepsy monitoring and diagnostic EEG procedures. In 2019, we had well over 400 admissions, and that was reduced to under 300 admissions in 2020. And we went through a period of time beginning in April of 2020 and through July of 2020, where we had a complete stop in elective admissions. And even at other times, we've had a reduction in the total numbers of admissions. So that was about a 30% reduction in 2020. And that's also reflected in the number of absolute days that our epilepsy patients spent in the hospital for diagnostic testing. This chart doesn't include patients who were admitted for acute medical reasons and required treatment. Also significant changes on the inpatient side with regards to visitation policies. So traditionally, we've had a fairly open door policy, but for much of 2020, there were complete visitor restrictions, except in unusual circumstances or in individuals that required direct caregiver support. So that affected, in some sense, our ability to do the testing that we like to do, because for patients that are having events, having a family member there that can recognize them is a huge benefit to us. Also, there were changes in policies with regards to even doing the admissions and the testing. So, patients prior to admission had to get COVID tested, which is, a lot of people will remember, early on in the pandemic was quite a challenge. One of our nurse practitioners spent a lot of time contacting patients ahead, trying to arrange locally for them to get tested, then trying to arrange for those testing results to be sent to us prior to their admission, and really only had a few days to do that for each of these admissions, and that was largely reflected in 2020. By 2021, with vaccines being widely available, and for much of 2021, a significant reduction in the number of hospitalizations related to COVID, we were able to bounce back to similar pre-COVID admission and patient days, able to resume elective procedures, certainly. And so things were much more closer to normal. With the most recent wave, the Omicron wave, even though we didn't see the substantial degree of critical illness, there was certainly a very high inpatient volume of patients. And as people may have heard, unlike other types of respiratory illnesses, COVID patients that ultimately are admitted to the hospital spend a much longer time there, on average, well over 10 days, whereas a typical flu admission, which is a different respiratory virus, would only be maybe 3 or 4 days. And so those patients built up a lot in the beginning of 2022. On the outpatient side, overall, we did well, both as an epilepsy group and as a department. So part of this is related to just an expansion in the number of providers that we have. Part of this is due to improved access directly as a result of telehealth. So as more of a tertiary referral center, we have a significantly higher proportion of patients that commute to see us from further away, even outside the Central Ohio region. And for epilepsy patients, transportation in that situation can become a major barrier. So those who were able to do telehealth appointments, it didn't require caregivers to take off of work. It didn't require for them to have to arrange medical transportation, which can be at times unreliable, especially when there's bad weather. And it was very beneficial. On the other hand, for individuals with poorer internet access or didn't have the type of smartphones that they needed to run the applications used for telehealth, that became more of an issue. And so, later on in 2020 and certainly in 2021, after vaccinations became available, we were able to better accommodate them for in-person clinic appointments. However, even those, clinic appointments were different than what a lot of people were used to. Just like there were restrictions in place for family members and friends to visit patients on the inpatient side, we weren't able to allow people accompanying patients to accompany them into their rooms. And for a lot of our epilepsy patients, that could pose significant difficulties where we rely on other individuals to help them describe things to us, to help them remember things that we need to know. This was also very different based on where you lived in the country. So Central Ohio was relatively spared overall compared to other areas. And so again, I mentioned areas where there was a complete lockdown, like Spain for a period of time, and like Italy for a period of time. They had zero outpatient visits for significant periods of time, and so there was clearly a period where patients didn't have the ability to get seen like they had been used to, and just something else that added to a significant amount of stress during this period of time. So these are some of our clinic locations within the Columbus regional area. And again, so regionally speaking, we were able to maintain a lot of our access that we were used to having, even though there was, in many cases, a modified format, whether that was an in-person visit or a telehealth visit. Also, it was different for us because on our side, because our clinic spaces aren't really designed to be efficient with telehealth. So for example, once we started having combinations of people seeing patients in clinic, there wasn't enough space in clinic to also have providers in clinic doing telehealth visits. So we had to expand our flexibility with computer access and locations for providers to contact patients from, that had the necessary video and audio equipment to perform those visits. Other factors that have come up in terms of epilepsy patients and our patient care is the potential for interactions between seizure medications and the COVID medications that have come out starting at the end of 2021. So for example, atazanavir, lopinavir, ritonavir, there's a drug-drug interaction that was found between lacosamide, which is a Vimpat, and eslicarbazepine, where there was potentially a risk of developing a heart arrhythmia as a result of that drug interaction. With remdesivir, which has been a more successful, more commonly used treatment, there's a potential interaction between carbamazepine, which is Tegretol, phenytoin, which is Dilantin, and phenobarbital, where the seizure medications actually reduce the amount of the antiviral drug in someone's system and may make it less effective in that situation. And then there was always the question of, on the inpatient side, if someone with epilepsy or who was on these medications became ill and needed treatment, should we try to change their medications? And generally in that scenario, you're facing a worsening of someone's underlying seizures. At the same time, they're already clinically more ill as a result of an infection that would require these type of antiviral drugs. Other issues that came up were with the ketogenic diet. So do people have access to the dietary support systems that they're used to having? Access to labs was concerning for a period of time because people didn't necessarily want to go in and get the testing done. And then also with immunosuppression, even though this is a small fraction of our epilepsy patients, those who are chronically immune suppressed not even necessarily because of their seizures or their seizure medications, but because of other chronic medical conditions, especially considering like autoimmune diseases and things like that. Does that put them at a higher risk? And if we're considering doing elective admissions or testing, or putting them in a position where they're going to have a higher probability of COVID exposure, are we going to wait to do any of that type of testing, or wait to do any of that type of treatment? The next topic was the interaction between patients, caregivers, COVID-19, and the overall healthcare system. And so early on in the pandemic versus now, the way we've approached things and thought about things has changed significantly. So early on in the pandemic, and really even in through 2021, there was this great concern that epilepsy patients would be at a higher risk to contract COVID, and at a higher risk to get sicker from COVID if they contracted it. And that's based on increased risk for morbidity, mortality among epilepsy patients with other acute symptomatic diseases. So early on, specifically, there were warnings from the CDC and other agencies about this, and as many people will probably recall, there was a priority early on in 2021 that in addition to elderly people with underlying chronic neurological conditions would be eligible for vaccination and should become vaccinated. That statement, based on the evidence that we've gathered over time, has been retracted to a large extent, because we just haven't seen that to end up being the case. Are epilepsy patients who get COVID more likely to get sick? This has been a difficult one to assess because of a limited availability of data. Also because persons with epilepsy represent a broad spectrum. So a broad spectrum both in age, where we'll have peaks in incidence in young children who would generally be considered less likely to become severely ill, and then a second peak in older adults, so people over 60 or 65, who would be inherently at a higher risk for more severe disease just based on their age. So in general, with the limited data that we haven't seen that become a significant trend, that our epilepsy patients who catch COVID have a more severe disease. But in individual cases, in particular, people whose seizures can be provoked by illness, fevers, that sort of thing, there's maybe a risk for increased seizures, which might present a more prolonged hospitalization than other patients, but we haven't seen that broadly. And then our epilepsy patients, were they likely to have worsened seizures during the COVID crisis? The answer to that was absolutely yes. So when I say we have limited data available, I just wanted to point out that it isn't because nobody was looking for things. So this is a review article that looked at what we did in 2020, not we as in Ohio State, but the worldwide epilepsy provider community. And there were, as you can see, several hundred research studies that were done specifically to look at that in 2019 and 2020. Those looked at the associations or interactions between the disease and seizures, the ones that looked at the effect on taking care of patients with epilepsy, ones that looked at mental health, that looked at the repercussions and problems we might run into with restricted access to testing and potential modifications to testing, and the effect on treatment. So this doesn't even include what had happened in 2021. So there was a lot of research and a lot of people looking into these impacts worldwide. So one concern was, would our epilepsy patients be at a higher risk to contract COVID? And is that based on living situation? Are they in more likely to be in close contact with high-risk individuals, more likely to be in close contact with larger numbers of individuals in group homes and institutions. So there was this large push with protective measures, like I mentioned, and that ultimately was retracted. And what we found is that compared to people with other neurological conditions, specifically conditions like multiple sclerosis, which is an autoimmune neurological condition, and people with dementia, which is a degenerative neurological condition, our patients were less impacted by COVID illness or contracting COVID than other patients were. And then, are epilepsy patients likely to have worsened seizures during COVID? And the answer was yes. And every single study that was done that looked at or tried to look at seizure frequency in epilepsy patients during COVID showed a significant increase in seizure frequency. So when you look at the increase in baseline seizure activity, there were a lot of factors attributed to it. So the attributed factors come from patient-reported questionnaires that were given at appointments, and none of these studies was done in Central Ohio, just for reference. These come from different centers around the world. And changes in sleep patterns were one of the really common factors, and this had to do with not just the individual patient's changes in sleep patterns because of changes in daytime activities, but also changes in sleep patterns in the household and the neighborhoods, and a change in people's awake patterns. So, people's activities were more fragmented, people's sleep became more fragmented, and there was a several month period of adjustment for people before they fell into a new sleep and wake, a new day-to-day pattern. COVID illness, whether that was the illness of a patient with epilepsy, or that was a illness in a caregiver of a person with epilepsy, that was one factor that patients attributed. Increased general stress was a really common factor. Having all of your normal activities disrupted and modified produces physiologic stressors, and physiologic stress has always been and probably always will be one of the major provoking factors for seizures in individuals that have epilepsy. And then another one was reduced income or income changes, whether that's in the household because of job loss or the individual themselves. There was also stress related to changes in people's work, our patients that do work, working from home, and that sort of thing. And I don't want to forget about epilepsy caregivers specifically. So our caregivers on the inpatient side had a reduction in access to their loved ones while they were admitted to the hospital. They had a reduction in access to their physicians when they were at clinic appointments. And for the first time, what we saw in a lot of our patients with developmental disabilities is there was significant morbidity among their caregivers who were often their parents. And it isn't something that we necessarily talk about a lot, but a lot of our adults with developmental disabilities are taken care of by older parents. And certainly we've seen, in individual cases, patients of ours who come back with legal guardians or people that aren't their parents, and in those situations, so much knowledge about them gets lost. Their parents know them so much better than certainly we do, or other people do, or legal guardians do, or group homes do. Just a lot of their information is lost, and it isn't something that we do a great job of pushing our parents of patients with developmental disabilities to create some type of a binder or something with that person's information, so that if something happens to them, that their knowledge isn't lost about their medications and their medical history and those sorts of things. Overall effects is reduction in direct communication, so reduction in face-to-face communication and communication time, and really a reliance on internet access and other telecommunications processes, which, calling in and leaving messages and us calling and leaving messages and things like that, and not being, face-to-face, a lot of information can get either misconstrued, a lot of things can get confusing, things can get changed, and it just has the potential to lead to more accidents, more mistakes, things like that. Next thing to talk about is the COVID vaccine. So this comes from the Ohio Department of Health website. This is a really recently updated image that they have, and Ohio is not a great example of high vaccination rates. Overall, we're at 56%. Now that takes into account younger children, which are naturally going to be at a lower percentage, but even overall adults over 18 were only at around 67%, and that's 13 months since the beginning of the availability of a free vaccine, and so that's led to more hospitalizations than we probably should have had, more severe illness than we should have had, higher mortality than we should have had. And so among our patients specifically, we wanted to look at or try to figure out as best we could, what are our patients doing? And it turns out generally our patients don't do well. So epilepsy patients watching this video are mostly not vaccinated. Certainly not vaccinated compared to people with other medical conditions. And people that have looked at this have tried to figure out, what are the factors that are most concerning to them. And typically the most concerning factor is people are concerned about their seizures getting worse from the vaccine. And there's, two parts to that discussion. The first part is, if you get a vaccine, could that cause you to have a seizure directly as a result of the vaccine? And then there's the concern about, well, if you get a vaccine, could that change, the overall trajectory of your seizures? So if you've been doing well with your seizures, if you get a vaccine, are you suddenly going to be doing worse again and then have to go through the typical cycle of medication changes and adjustments and dealing with side effects and stuff like that? Another factor, which was really surprising, was that epilepsy patients, more than people with other conditions, were discouraged from getting the vaccine, and not just by people that they know, but discouraged by other healthcare workers about it, because there was concern that it could worsen their seizures or something like that. And then there was fear about side effects of the vaccine, which is something we've seen generally in the general population as well. The one thing we know for sure is that people with a COVID vaccine, if they become ill with COVID, they're not going to get as sick as if they don't have a vaccine. And so, the decision whether to get vaccinated or not really comes down to what someone thinks his or her ability is to cope with a severe illness, and what impact they think that illness might have on the people around them, the people that they interact with exposures and things like that. But overall, we haven't done a great job in this area. Changes to healthcare moving forward. So telehealth, and one thing about telehealth is that there's a lot of room for improvement. So none of us who are neurologists today, none of us had any training on how to do a telehealth appointment before the COVID pandemic started. And in 2020, we had to switch to using telehealth. We had no training. We still haven't had any training. We're learning along the way, just like everybody else is. And in speaking with people that live in other parts of the country, other countries, there are a lot of different ways that people are doing these appointments. And there's absolutely room to make the appointments better for people. So what we really had focused on initially when we were doing these appointments was, how closely can we approximate this video appointment to what people expect and what providers expect from an in-person appointment. And what has probably come out of that is that a better process would be, since this is a telehealth appointment, how can we take advantage of that and make it as good as possible of a completely different type of appointment? And that comes from, our side, on the provider side, and it also comes on the patient side. And clearly there are limitations on the patient side. If the problem is that you don't have a phone that can do a telehealth appointment, or a computer, or good internet access, then you're really going to be limited. But is there a way that you can go to a place that has the access to those things to do your appointment, and that's close by enough that can be available for you if you don't have it yourself? On our side, is there a way that, because we spend a lot of time sending links out to patients and waiting for them to answer, is there a way for somebody to contact patients and then keep them ready and waiting, and give them information? Is there a way for them to gather information while they're waiting for us to join in that conference? And then we might be able to improve our access by having an increase in encounters, being able to provide those services to even more people in a given period of time. The second part of moving forward is going to be our return to normalcy. And this is a moving target, because we don't know what's going to happen with the COVID virus locally, regionally, nationally, or internationally. So, depending on case rates in the community, case rates in the state, depending on what we discover about new variants that are likely to come by, all of these things are going to be moving targets, and all of the restrictions that we saw before may come back again. And this time we'll be, more used to addressing those things when they come up, because we've done it before this time. And then a reduced restriction for access. So, like we saw in 2021 and 2022, the limitations that we had on the inpatient side have largely been removed. And we're largely doing everything that we had done before in terms of treatment and testing for our patients. Still have, changes to the outpatient procedure or outpatient clinic models, but those things are likely to change. Mask mandates are being minimized or reduced. Although I don't know how, at what point, removing masks and mask mandates in places like hospitals and stuff like that would occur. And then the other thing with telehealth is we've hired people who are experts in telehealth. These are our young physicians who are becoming sort of our leaders in this area. And Dr. Jha specifically was a resident here that went down to Texas to study stroke, and then we've hired her back to hopefully help us optimize our processes with telehealth. And so, out of COVID, we have a brand new specialty in medicine, which is teleneurology, and she's an expert in that. I'd like to thank the organizers for inviting me to give this talk. It's a pretty broad overview, but hopefully an update on all the information that we've gathered over the last couple of years with regards to COVID and our seizure patients. And if you have questions, I believe that there'll be time that I'll be available, and I'll try to answer them as best as I can. Thank you.